Start my special regards to all my teachers who made a radiologist that I am today. So today, in the next 40-45 minutes or so, I will actually take you through the clinico-radiological approach to actually reach a diagnosis in cases of vasculitis and what the special role of a radiologist is in making this possible. So in today's session, I will be taking you through the classification of vasculitis, the clinical approach to the diagnosis, how imaging plays a role in it, what is the role of certain serum biomarkers in making this diagnosis. I'll also dwell upon the specific imaging features of various vasculitis before I conclude by briefly touching upon the vasculitic mimics as well. So generally, your vasculitis involves an inflammation in the vessel wall. So it can be either a primary involvement or a secondary involvement. Basically, your secondary involvement means that you are having an underlying disorder, which can be either an infection, a malignancy, it can be drug related, which is the actual offending agent that causes your inflammation in the vessel wall. Largely in today's session, we'll be considering mostly the primary vasculitic pathologies. So coming to the classification, it was only until 1994 when the initial lay classification came that actually vasculitis was classified based upon an objective criteria of what is the kind of vessel, or more precisely, what is the size of the vessel that this inflammation predominantly involves. So it was in the same year that the most widely used Chapel Hill consensus first version came upon into being, and later on went on to be modified in 2012. And it is this modified Chapel Hill consensus which is now being widely used to classify this vasculitis. Now, the product of this consensus is that it is not basically a diagnostic criteria or a diagnostic approach to vasculitis, but it generally categorizes your vasculitis into various heads. So you have vasculitis that involves predominantly your large vessels, which includes your aorta and its proximal branches, and also the associated closely related great veins as well. The medium-sized vessels are mainly your visceral branches, which involves mainly the medium vessel arteries rather than predominantly the veins. And you have small vessel vasculitis, which will involve your arterioles, capillaries, and in few cases, it can also involve your venules. So coming to this modified Chapel Hill consensus, and this classification actually forms the basis of my entire talk today. So if you're thorough with this chart, your vasculitis becomes slightly more easier to understand. So basically divided vasculitis into large vessel, medium vessel, and small vessel. There were certain vasculitis wherein you could not actually classify them into the predominant involvement. So those vasculitis were classified under the variable vessel vasculitis, which mainly involves your large vessels as well as your medium vessels. You also have disorders or vasculitic disorders which are isolated and particularly involving only certain organs. So your primary CNS lymphoma does not come under any of the other vasculitis. It comes under the single organ vasculitis, and it will have imaging features which are pertaining to that particular organ. You also have vasculitis which are associated with systemic disorders and with a probable underlying etiology. So your large vessel vasculitis per se is your granulomatous vasculitis, the most commonly being and the most widely studied Takayasu arteritis and your giant cell arteritis. Your medium vessel vasculitis includes your polyarteritis nodosa and Kawasaki disease. Your small vessel vasculitis is categorized into two categories based upon whether they are ANCA positive or ANCA negative. The ANCA negative ones are generally immune complex based vasculitis. So your ANCA positive vasculitis will have your microscopic polyangiitis. It has eosinophilic granulomatosis with polyangiitis. And this is what is basically generally your Churg-Strauss syndrome, and granulomatosis with polyangiitis, which is basically your vaginous granulomatosis. In your complement-based small vessel vasculitis, you have your Goodpasture syndrome, your cryoglobulinemic vasculitis, IgA vasculitis, which is otherwise known as the Henoch-Schönlein purpura, and hypocomplementemic urticarial vasculitis. In your variable vessel vasculitis is where your Cogan syndrome and your Behcet's disease comes. As already mentioned, your CNS vasculitis, cutaneous, all comes under single organ. Systemic illness with vasculitis includes your rheumatoid, lupus, sarcoid, and IgG4 related diseases. And you have drugs, malignancies, and infections coming under vasculitis, which has got a probable etiology. The role of the radiologist primarily when it comes to vessel imaging is largely to make a diagnosis of your large vessel vasculitis and medium vessel vasculitis, and to an extent your variable vessel vasculitis. Radiologists have a crucial role in making a diagnosis of small vessel vasculitis, but it's not per se directly an imaging of the vessel, but it is an end result of what disorders or organs they involve. And most of these would be mostly localized towards the lung parenchyma. So before we go into the specific imaging features, how do you actually reach a diagnosis of vasculitis is one thing that we need to know. So whenever you have a patient who is a suspected vasculitis, that generally means you have a patient who has a systemic illness, who have been worked up for various commonly occurring diseases, and it has turned out to be negative. So in order to establish a diagnosis, you need to have a combination or a correlation of your clinical findings, your laboratory workup, if needed a biopsy, and more importantly, a radiological evaluation, which may involve an angiogram or an ultrasound evaluation. Based upon this, you need to look whether the patient actually falls into a specific vasculitic syndrome. And if he does, what kind of syndrome does the patient actually fall into, and then proceed with treatment. Now, before you actually treat, you also need to know what is the extent of the vasculitis and the pattern of vasculitis. Always before you label a patient to be having a particular vasculitis, you also need to make sure that there is no underlying offending antigen or an underlying disease. Both of these, if present, needs to be dealt with separately in order to make sure that the patient benefits from treatment. So coming to the role of imaging in vasculitis, the first and foremost role of imaging is one in making a diagnosis of a particular vasculitis or a pattern of vasculitis that is involving the particular patient. It can actually supplement your biopsy, especially in cases of your large vessel diseases, wherein you don't have a tissue for biopsy. So in those cases, to make a diagnosis, actually, you need to rely on your imaging. Also, it will complement biopsy, especially in cases of giant cell arteritis and in many other pathologies where blind biopsies are told to be actually yielding negative reports. So you need, if you are able to identify areas of thickening that is involving certain peripheral arteries, as in giant cell arteritis, you can biopsy that particular segment in order to make sure that the biopsy comes out with a better yield. You also need imaging in order to identify the sites and the extent of involvement, the severity of the disease, and also in prognostication, because one of the most important predictors of morbidity and more so for mortality is the involvement of cardiac structures, especially coronary artery. And hence coronary artery involvement, especially with cardiac CTs or coronary CTs, will help in prognosticating the particular vasculitis. And as we are mostly aware, the monitoring disease activity in vasculitis, this imaging plays a special role. Also, complications that are secondary to vasculitis, as well as in guiding treatment planning, because if you want to do a surgery or for that matter, any endovascular intervention, you need to do it at the time that the disease is in its quiescent stage. So you have imaging modalities wherein you can actually predict the disease activity and do interventions based upon and the inactive stage of the disease. And also post-operatively, you can survey the patient based on your imaging. So all the imaging modalities does have its own role in various vasculitis. Your ultrasound is able to detect vessel wall thickening, especially of superficial arteries, as in this case. Your Doppler can detect stenosis along the course of the arteries. And also it has been described in recent papers that your contrast enhanced ultrasound will show contrast uptake in the inflamed vessel wall. However, these uptakes of contrast can also be seen in atherosclerotic plaques as well, as is the principle to detect vulnerable plaques in your contrast enhanced ultrasound. CT is one of the main modalities in order to assess your large vessels per se, wherein you can see the circumferential hypovascular wall thickening that is involving the aorta, as well as in depicting your aneurysms, stenosis of the distalmost arteries. Your MRI has a role also in depicting the vessel wall thickening in your T1 as well as T2, in addition to the T2 wall edema. Your MR angiographies, especially your non-contrast angiography, can depict the stenosis as well as the aneurysmal segments within the vessels. Also, your post-contrast images can clearly depict the vessel wall inflammation as well. Per se, the advantage that your PET offers when compared to most of your other imaging modalities is that it has got the best predictor value for actual active disease status. So your PET CT and your PET MR has the edge over other modalities, especially in predicting the disease activity. DSA or your angiography per se does not entail much for a diagnostic purpose, but usually they are required when you're planning an intervention, and especially in patients where you're having a borderline narrowing, especially in your renal artery. If you're imaging, you're seeing around 50 to 60% stenosis of your renal artery. You need to decide whether they are actually hemodynamically significant or not. You can take pressure measurements on either side of the stenotic segments. And if it is significant, you can go ahead and do your endovascular intervention. So I think we can start with few of the cases. So this one was of a 38-year-old female who presented with a complaint of chest pain. So 38-year-old female with complaints of chest pain. I think a poll should be visible on your screen right now. Is it visible?
Yes, sir.
Yeah, okay. So the diagnosis may be relatively very easy. So to make it a bit more interesting, I have not added the diagnosis as the poll question. As the poll is on, I'll just go through the imaging findings. So what you're seeing is a CT coronary angio that is showing the tortuous collaterals which are centered around the scapular region. You're seeing the diffuse wall thickening involving the pulmonary arteries, and you are, as I told, the patient presented with chest pain. As you can see in the present cardiac MR, the echinacea involving the lateral wall of the LV myocardium, which is showing subendocardial enhancement, which is an evidence of myocardial infarction. So basically, this is a vasculitis that is involving, because there are collateral involvement in the supraclavicular that has involved the subclavian artery. I think it becomes easier if I have the PRTs. So you can see diffuse narrowing of the aortic arch branches, complete occlusion of the subclavian arteries on either side. You're having pulmonary artery involvement. You can probably have this MI was secondary to coronary arterial involvement as well. So the poll results are, I think the poll results should be visible. Are you able to see the poll results?
Yes, we can.
Okay. So in the few slides that come up next, we'll see what exactly is. So the diagnosis is basically a large vessel vasculitis, mainly a Takayasu arteritis. So generally it is a large vessel vasculitis that occurs in around the third decade or so, with patients presenting with systemic clinical features with evidence of arterial stenosis. So it is basically a pan-arterial inflammation, but the inflammation actually starts from the adventitia, the outer aspect of the vessel wall. And it has predominant involvement, in addition to your aortic arch and the aortic arch branches, of your pulmonary artery, your coronary arteries, with subsequent thrombus formation. And more importantly, with regard to Takayasu arteritis, because it's the most widely studied arteritis, is the ethnic difference. The original description of Takayasu arteritis was actually in the Japanese population. There was a larger incidence of involvement of the aortic arch branches and the aortic arch itself. So, and those majority of subset of population actually had stenosis of these arterial tree. Now, when the Indian subset of populations and to an extent the American subset also was studied, it was found that predominantly our subset of population has more of abdominal aortic involvement, and there was a higher incidence of aortic aneurysms in our population. So where does your Takayasu mainly involve? It mainly involves your trunk branches of the aorta as well as the proximal subclavian as well as the axillary artery. So you can have occlusions, stenosis, aneurysms of your aortic arch as well as its branches. You can have collateral secondary to that. You can have involvement of your abdominal aorta. You can have involvement of your subclavian arteries with aneurysms. You can have involvement of the coronaries, the pulmonary arteries, and these inflammatory processes can actually descend along the aortic wall to involve your aortic valve as well. You can also have myocarditis and pericarditis as associated involvement in Takayasu arteritis. So this was another case of Takayasu arteritis, which has got aneurysmal dilation of the ascending aorta with wall thickening, involving the entire aorta, thoracic aorta, extending till the hiatal level. Your MRT2 fat suppressed images showing the concentric hyperintensity involving the vessel wall, indicative of an active disease. There were also studies that actually evaluated the role of diffusion in actually identifying active inflammation, as in this case with diffusion hyperintensity and diffusion restriction as is depicted in the ADC maps. So the diagnostic criteria of Takayasu initially was the Ishikawa's criteria, which had a mandatory less than 40 years criteria with subclavian artery lesions as major, and the other minor criteria with involvement of your pulmonary, your abdominal aorta, DTA, and brachiocephalic and CCA branches. Now, the primary criteria, the original criteria actually told that there should not be involvement of the aorto-iliac junction as well as the iliac artery. The American College of Rheumatology also came up with a criteria later on with mostly clinical criteria, with arteriogram being only one of the minor parameters within that. Now, the sensitivity and specificity of these criteria in actually identifying Takayasu patients in general was around 70 to 80%. But when this criteria was actually applied to the Indian population, and probably due to this ethnic variation, there was the sensitivity of the original Ishikawa criteria actually dropped down to 60%. And it was for this fact that in 1995, there was a Sharma's modification, Sharma being internal medicine physician. He was the head of department in PGI Chandigarh, who came out with this criteria, wherein he removed the obligatory age criteria. He added characteristic symptoms as one of the major criteria, also added coronary artery lesions, and also that rider, that abdominal aortic lesion may or may not involve the aortoiliac region. So with this modification, actually the sensitivity in detecting Takayasu came up to around 80 to 85%. And also you have an angiographic classification on the distribution of involvement, wherein you have type 1 that involves the aortic branches, type 2 basically involves the thoracic aorta, wherein 2A involves only till the subclavian artery. Your type 3 involves the thoracic as well as the abdominal aorta, and your type 4 involves your abdominal aorta, and your type 5 involves the entire aorta, of which your type 5 is the one that is the most common. Now, it is very important not only in diagnosing Takayasu arteritis, but it's very important to actually know whether the disease is active or not in order to decide your treatment management. So there were studies that evaluated a lot of your serum markers, and still the most widely used is actually your ESR and CRP. But lately they have found that the most sensitive and specific parameter is actually your serum pentraxin 3, which is a serum agent with levels more than 1 nanogram, indicating that you are 70 to 75% likely to have a disease activity. And recently there were also papers that a combination of your complement C3 along with CRP, the sensitivity in detecting comes to around 90%. With respect to per se imaging, actually, as I mentioned earlier, your PET CTs and MR has got a slightly better edge in predicting your disease activity. And not only in the initial assessment of activity, your interval change can also be detected based on your imaging. So usually in Takayasu, your aortic wall changes would actually occur if adequately treated in about 6 to 12 months. And in fact, for your giant cell arteritis, this resolution of wall thickening and all actually appears even as short as within 2 weeks of your steroid induction. So there were criteria and scoring systems that combined your clinical and radiological scoring systems, which are now available online as well. So DITAC is the disease extent index for Takayasu. The ITAS is the Indian Takayasu scoring system. Now, both these are generally, most of the parameters in this are clinical parameters pertaining to each of the systems based on which you develop a scoring. Now, there was a modification to the ITAS, which is called the ITAS ARAT score, which included 3 imaging features, which has the highest valuation weighting factor in order to get the final score. So you have any vessel, new vessel involvement, you have progression of vessel wall thickness on a B mode USG, and the presence of vessel wall edema are the 3 parameters which are now being added into this particular scoring system. Now, the European League Against Rheumatism has actually come with certain guidelines for imaging, and it is told by the particular guideline that presently MRI is the initial first line investigation of choice, especially because it will give you an idea with regard to disease activity slightly better than CT. It will give also additionally an assessment of the luminal changes as well. And that is the advantage over your PET CT or PET MR. And that is why they have actually concluded that MRI should be the first line of investigation when you're dealing with your with your Takayasu arteritis. All your other imaging modalities may be considered as alternate imaging modalities. And if you're clinically suspecting a flare, you need to do an imaging. And if you're clinically sure the patient is in remission, you need not do imaging. And per se, there are no guidelines for Takayasu on how routinely you need to follow up these patients. So the first pop-up quiz that was shown had Indians with disease at predominant aortic arch and branch involvement. Actually, they have more of abdominal aortic involvement, more of aneurysms, unlike the Japanese or the Western population. It's not the type 3, the type 5 is the most common angiographic type. CT and CT angio is not the first imaging modality. It's actually MR with MR angio. And it is true that the inflammatory process starts at the vasa vasorum, but in the adventitia, but eventually it will go on to involve your complete vessel wall thickness. So this is the second case. So I think the poll is live. This is of a 48-year-old female who presented with headache and body ache. I hope the poll is visible. Okay.
Yes, sir.
Again, the question is on what is true about this vasculitis, whether it's associated with varicella zoster, inflammation starts in the outer adventitia, it's a necrotizing vasculitis. The subclavian arterial involvement is more common. So basically, this is a temporal artery Doppler that shows stenosis irregularities in the temporal artery. Also doubtful wall thickening in the proximal part. You can clearly see the circumferential enhancement and thickening involving the temporal artery in the post-contrast MR. So basically, this is undoubtedly a case of giant cell arteritis. I think the results are also visible. So, right. Okay. So giant cell arteritis is generally again a granulomatous vasculitis that affects patients who are above the 5th decade. We all know that it is largely involving your extracranial carotid artery, so most commonly your temporal artery. But most of us don't know that it can actually involve your large vessels as well. So there is a variant that involves both your cranial as well as the large vessels. And there is even more a variant that has isolated large vessels. So it will mimic like a Takayasu arteritis. Largely, it will have involvement of your ascending aorta, the aortic root with aortic root aneurysms. The problem with this isolated large vessel giant cell arteritis is that it usually affects a younger age. It usually presents at around 30 to 40-year-old patients. And also your inflammatory markers, especially your ESR, is usually lower when compared to your cranial involvement of your temporal artery. You also have association of what is known as your polymyalgia rheumatica. as well as varicella zoster and your other bacterial infections as a causative agent for your giant cell arteritis. And inflammation, unlike in your Takayasu arteritis, actually starts at the junction of your adventitia to medial border. And it is important also to note that whether it be mostly a cranial giant cell arteritis or an extracranial giant cell or your isolated large vessel giant cell arteritis, larger majority of both these subset of patients will have this polymyalgia rheumatica, which mainly involves morning stiffness of joints associated with other muscle pain. Where does this most commonly involve? It mainly involves your proximal trunk as well as the extracranial carotid arteries. So your temporal arteries, your vertebral arteries. When you go to the peripheral arteries, actually it has a special predilection for involvement of your axillary arteries, much more common than your subclavian or your brachial arteries. You also have involvement, this is a case of your brachial arterial involvement. You have involvement of coronary arteries, your ascending aorta. You can have valve involvement with aortic regurgitations, myocarditis, as well as pericarditis. The diagnostic criteria states an age more than 50 with new onset of headache. You should have an abnormality of temporal artery, which can be either a bruit or a tenderness. You need an ESR, which is more than 50, and an abnormal arterial biopsy. Now, there are certain changes which have recommended that in this biopsy case, even an abnormal imaging, whether it be ultrasound, PET, or MR, may be enough for the diagnosis of your giant cell arteritis. As far as guidelines go, if you are having a high clinical suspicion and your imaging test is positive, it means that you need not work up the patient further. You can label the patient as having a giant cell arteritis. However, if you're having a low clinical suspicion and your imaging test is also negative, it is highly unlikely. In all your other situations, you need to go on to the next level of investigation, which mostly involves your temporal artery biopsy. Now, where does temporal artery biopsy stand is basically the problem with temporal artery biopsy, and especially with regard to your giant cell, is that there can be skip lesions and you may be dealing with your large vessel giant cell arteritis, in which case your temporal artery biopsies may actually turn out to be falsely negative. Now, what is the imaging modality that you need? The guidelines say that the first modality that you need to do is your ultrasound with Doppler, because that can depict the vessel wall thickening, as well as your Doppler parameters can depict the stenosis involving the artery. And this is the first line when it comes to your cranial giant cell arteritis. Your CT and especially PET are not recommended for your cranial, especially because your brain has high uptake of your FDG, and hence the uptake within your temporal artery will not be depicted clearly. MR angio may be considered as an alternative, whereas your extracranial giant cell arteritis, you can use CT and your MR angio for evaluation. Per se, your conventional angiography does not come anywhere in the guidelines for imaging. So the question was with regard to your giant cell arteritis. What is true is actually the varicella zoster association. It does not, inflammation does not start in the outer adventitia. It's actually in the adventitia media junction. It's not a necrotizing vasculitis, it's a granulomatous vasculitis. It has slightly more predominant involvement of your axillary artery when compared to your subclavian artery and brachial artery. And in fact, if you there are also studies that have told that if you do a Doppler or an ultrasound evaluation, when you have a suspect of giant cell arteritis, you need to evaluate your axillary artery. And if the intima medial thickness of the axillary artery, if it is more than 1 mm, it is almost 100% sensitive for your giant cell arteritis. So next time a patient with a suspected giant cell arteritis comes to you for a Doppler evaluation of the temporal artery, make sure you also have a look in the axillary artery as well. So this is the next case. So this was okay. So this was a 23-year-old male with complaints of left hypochondrial pain. We also had a doubt whether this patient had a history of some trivial trauma as well, but per se, this is angiogram study or with the catheter hooked into the splenic artery that is showing areas of contrast pooling in relation to the splenic hilum as well as intraparenchymally. You see smaller ectatic or smaller dilated areas here with distal irregularities within the splenic parenchyma. This was the renal angiogram that also showed smaller focal dilations in the intraparenchymal renal arteries as well. As you probably might have made the diagnosis by now, it's a case of polyarteritis nodosa. I think the poll result should be now visible as well. So what we are dealing with is mainly a medium vessel vasculitis. So this is a necrotizing arteritis again. And when compared to your other vasculitis within the medium size, your Kawasaki's, this generally has a subacute onset that is much more common than adults when compared to your Kawasaki, which is more common in children. Now, these patients usually present with hypertension, they can present with hematuria, but never will they have glomerulonephritis. So if you have glomerulonephritis in a patient who has a suspect polyarteritis nodosa, those patients are mostly having what is your microscopic polyangiitis and not PAN. So you have an association with hepatitis B virus as well, and it is these subset of patients with PAN and hepatitis B virus infection are more likely to have your coronary artery involvement with coronary artery aneurysms as well. So the predilection is mostly centered in relation to the visceral arteries. You can have aneurysm stenosis of the mesenteric vessels, as in this case of SMA. There can be florid irregular narrowing and ectasias involving all the mesenteric vessels. You can have involvement of the renal artery, as in these cases with microaneurysms, which are the cause for your hematuria. You can have coronary arterial involvement and also rarely involvement of your ECA branches, as in this case with involvement of the lingual artery. So coming to the diagnostic criteria for PAN, in general, you have weight loss, libido reticularis, testicular pain, you have myalgia, neuropathic symptoms, you have hypertension, deranged renal function test, you have hepatitis B antigen, you have the angiographic abnormality where the radiologist actually comes into the role, and you can also have biopsy to make a diagnosis of polyarteritis nodosa. In generally, your polyarteritis nodosa will not involve your pulmonary artery, but the only artery that it can involve when other than your visceral, when compared to your lung, is basically your bronchial artery involvement is basically described. So the question was with regard what is true. It's not hepatitis C, hepatitis B infection with which it has association. Glomerulonephritis is invariably present. No, it should not be present. If it is present, you need to reclassify your vasculitis to the microscopic polyangiitis. It can present with myalgia, myositis symptoms, and it's not true that it does not involve your coronary arteries. So this is the next one. So this was a 3-year-old boy who presented with pedal edema and basically symptoms of cardiac failure. So basically what you're seeing is the cardiac CT images, which shows fusiform aneurysmal dilation of your left coronary arteries, your right coronary artery. The aneurysm is extending along your left anterior descending as well as your circumflex arteries. This is the short axis views that shows involvement of your LAD as well as your RCA, the same in the 2-chamber view as well. So basically this is a case of a Kawasaki's disease. So hope the results are visible as well. So in general, Kawasaki's disease is a self-limiting. It's a self-limiting acute necrotizing vasculitis, and it can not only involve your coronary arteries, it can virtually involve all your organs. It's part of the subset of lymphocutaneous syndromes, and invariably it usually happens in patients who are less than 5 years. And Kawasaki's disease is one of the things you need to suspect when you have unexplained fever for more than 5 days in the pediatric population. And this finally leads on to be one of the major cause of an acquired childhood cardiovascular disease as well. So where commonly it mainly involves your coronary as well as your axillary, subclavian and brachial artery. So you can have coronary arterial involvement with ectasias involving your coronary artery, aneurysms involving your coronary arteries. With regard to your coronary arterial involvement, it usually causes thrombosis of the right coronary artery. It rarely causes thrombosis of LAD. Mostly LAD, there will be aneurysms. RCA is most likely to go for thrombosis. In the acute stage of Kawasaki's disease, there can be aortitis. So there can be inflammations that are involving your ascending aorta most commonly. You can have involvement of the subclavian artery and your axillary artery, your pericardium, and the most common extracoronary manifestation of your Kawasaki disease is actually myocarditis. It can also involve your aortic valve most commonly, and rarely also iliac arteries as well. So the criteria for diagnosing a Kawasaki's disease is mainly clinical, with your conjunctivitis, your oropharyngeal lesions, rashes, and skin lesions. Probably the only role to an extent maybe to visualize your cervical lymphadenopathy in your ultrasound. Largely, it's a clinical diagnosis for the diagnosis of a Kawasaki, but for the manifestation and complication of a coronary artery aneurysm, the radiologist has a role. So it does not exclusively involve the coronary vessels. Your other vessels can also be involved. It's basically a necrotizing vasculitis. Aneurysms are more common in the LAD. Thrombosis is more common in the RCA. And lately, it has been told that there is an association with COVID-19, which we'll see later on in today's session. So the actual true statement is its association with COVID-19. So this is the next case. Okay. So this was a 11-year-old female who presented with hemoptysis. So what we are seeing is CT cardiac as well as volume rendered imaging that shows fusiform dilation of the left intraparenchymal pulmonary artery here. There is complete thrombosis of the right pulmonary artery. What you probably should not miss is the small saccular aneurysm that is arising from the infrarenal abdominal aorta as well, which has got a wall thickening also surrounding this small aneurysm involving the infrarenal abdominal aorta that is also seen in the volume rendered imaging. So to make it a bit more easier, I've this time asked what is the diagnosis in this particular case. And I think most of you have got it right as well. So hope the result is visible. So this was a case of Behçet's disease. So basically what we are going to see are the variable vessel vasculitis. In generally, these are vasculitis that can involve any vessels, but predominant to a larger extent, it will involve mainly your large and medium-sized vessels. And in addition to that, there will be certain systemic features as well. One of the most rarest disorders to make a diagnosis is one of your Coggins disease, wherein this is an inflammatory disorder that has got ocular lesions as well as audiovestibular lesions and involvement of your aortic root and the aortic branches. So just like a Takayasu, you're having symptoms that are pertaining to your eye as well as your audiovestibular areas with aortic involvement. You need to keep in mind a diagnosis of Coggins disease. And this mainly causes aneurysms as well as stenosis of the aorta and its proximal branches. The other variable vessel vasculitis, of which the case was also shown, is your Behçet's disease, which has got that particular predilection to cause thrombosis. So these patients have increased incidence of your DVTs as well as superficial thrombophlebitis. This is one vasculitis which is more common in males, unlike all the other vasculitis which are mostly seen more commonly in females. And these are also seen mostly in adults, wherein your vascular symptoms may actually precede the ulcerations and mucosal lesions that are typical of Behçet's disease. Aneurysms, in addition to your aorta as well as your pulmonary and subclavian, can also be seen in relation to your popliteal artery as well. And one of the most commonest cardiac abnormality in your Behçet's disease is actually pericarditis. And there is a variant of your Behçet's disease, which is your Hughes-Stevens syndrome. In general, Hughes-Stevens syndrome is considered if you have areas of involvement which is similar to Behçet's. So if you have an aortic or a pulmonary artery aneurysm along with DVTs or thrombophlebitis without the mucocutaneous symptoms, you make a diagnosis of your Hughes-Stevens syndrome. Now, my talk today will not.
Doctor, sorry to interrupt. Please close the poll window because it's hiding the screen.
Okay, sorry.
No problem.
It's fine now.
Once the poll is over, please close the poll window. Otherwise, it's hiding the page.
Okay. So today my talk will not be over unless I briefly touch upon small vessel vasculitis. As I told, small vessel vasculitis does not involve direct imaging of the vessel wall. So generally, these are vasculitis that involve your intraparenchymal vessels. So you have ANCA positive vasculitis as well as your ANCA negative ones, which are generally your immune complex based vasculitis. So your ANCA associated ones are your eosinophilic granulomatosis with polyangiitis, your granulomatosis with polyangiitis, and your microscopic polyangiitis. This is basically your Churg-Strauss syndrome. This is basically your vaginous granulomatosis. And you have immune complex mediated, which is your hypocomplementemic vasculitis and your cryoglobulinic vasculitis. So to reach a diagnosis of eosinophilic granulomatosis, you need either the presence of asthma, increased blood eosinophil count, and evidence of necrotizing vasculitis. The radiologist can help in making a diagnosis because cardiac involvement is most, among the small vessel vasculitis, it is most commonly seen in this particular subset. So you can depict evidence of myocardial edema as in your T2 stir images. You can see subendocardial enhancement along the LV as well as the RV wall. You can have multifocal thrombi, intracavitary thrombi, most of which are eosinophil-rich thrombi in these cases of eosinophilic endomyocarditis. You can also have these fleeting opacities which involve the lung parenchyma, which is a marker to your eosinophilic pulmonary pneumonias as well. When it comes to your vaginous or your granulomatosis with polyangiitis, in addition to the diagnostic criteria that envisages abnormalities in your chest radiograph, which show typical cavitating multifocal lesions, you can also have your imaging of your paranasal sinuses with your CT or your MR, which will also point towards the diagnosis of your vaginous. To an extent, your microscopic polyangiitis is largely a clinical as well as a pathological diagnosis. But if you see large eschar-like lesions involving lower limbs, that is again a pointer towards a diagnosis of your microscopic polyangiitis. Your cryoglobulinic vasculitis is generally associated with your other systemic disorders like your lymphoproliferative disorders, your Sjogren's syndrome, which also has mainly clinical, serological, and histopathological diagnostic criteria. Rarely, these subset of patients can present with pericarditis, wherein we might have a role. These patients will have purpural lesions in the skin when compared to the urticarial lesions in your urticarial vasculitis. And there are reports of inflammatory infiltrates as well as ischemic insults secondary to vasculitis involving the coronary artery in your cardiac MR as well. But per se, without a history of these hypocomplementemic vasculitis, we will not attribute these scars to the underlying vasculitis. You also have vasculitis which have part of your systemic abnormality. So you can have vasculitis in your rheumatoid arthritis where there can be aortic involvement, your SLE, your sarcoid, and the lately being described widely IgG4 related disease, wherein you can have aortic wall thickening, you can have autoimmune pancreatitis, and you can have soft tissue lesions that encase your coronary, DDs of which include your lymphoma or your Erdheim-Chester disease in addition to other metastatic lesions. You also need to be aware of certain vasculitic mimics. Now, these are subset of disorders which are not considered to be part of the original vasculitic pathology, at least for now. So you have your Burgess disease, which are occlusions that occur with corkscrew collaterals that are formed in chronic smokers. You have cases of fibromuscular dysplasia, which are gently dysplastic changes that occur in the collagen, and they are not an inflammatory process. You also have a subset that is called as a mid-aortic syndrome. Now this is a gray area and slightly controversial as well. There are descriptions whether this is actually part of Takayasu arteritis per se itself, or whether this is a separate entity itself. So this mid-aortic syndrome is still a gray area. And you have segmental arterial mediolysis. Now this is a specific disorder that develops lysis of the smooth muscle media, especially of the visceral arteries. So that can cause dissections as well as aneurysmal dilations of your mesenteric arteries. You also have, because as I said in Behçet, you can have thrombotic complications. DIC is one of your differentials. So in these cases, you need to correlate with your fibrinogen levels, which will be reduced in DIC, your D-dimer levels, which will be elevated in your DIC. Other collagenopathies like your Marfan's syndrome, your Louis-Dietz syndrome, all those are disorders of collagen formation and they are not considered to be part of vasculitis. Your neurofibromatosis also is not part of your vasculitic spectrum. You also have your APLA syndromes, your TTPs, all of which are hypercoagulopathic conditions, which are also not actually categorized or comes into the ambit of your vasculitic disorders. And rarely you can have infections like your syphilis, Lyme's disease, your rickettsial infections that can also have features that involve, that can have pictures that depict a vasculitic pathology as well. And my talk again will not be incomplete, it will be complete in today's times without having a reference to COVID-19. Now, as we already know and most widely being told around is that the major cause for thrombosis in COVID-19 is thought to be a result of the immunogenic reaction. So it's basically immunothrombosis. But there are studies that have actually shown that there is also evidence of an underlying endothelitis or an underlying vasculitis, which can cause your DVTs as well as your arterial thrombosis. And there is a likely clinical picture that says that you can have isolated skin vasculitis. You can have diseases that mimic a Kawasaki disease or a Kawasaki-like disease, especially in the pediatric population. So if you were lost during my session and you've lost completely, you have not got an idea with regard to your vasculitis pathology in my last 30 minutes, I think the next 5 slides will make it much more simpler for you. So if you have a temporal artery involvement, you need to consider your giant cell arteritis in your differential. If you are having a pulmonary arterial disease, you need to look whether it is an aneurysm. So if it is an aneurysm, your differentials would be one of Behçet's disease or a Hughes-Stevens syndrome. If you're having a pulmonary artery stenosis, it's more likely a Hughes-Stevens or a Takayasu arteritis. If you're seeing lung parenchymal nodules which cavitate, then you're thinking it in lines of your vaginous granulomatosis or your GPA. If you're seeing diffusely extensive opacities or fleeting opacities, you're thinking in terms of your eosinophilic vasculitis or your microscopic polyangiitis, your IgA, your drug-induced vasculitis, or your Goodpasture's disease. If you're seeing TREAM bud, you again need to consider your granulomatosis with polyangiitis. Now, when it comes to coronary artery involvement, mostly with aneurysms, your first differential is always a Kawasaki disease. You need to also consider Takayasu and eosinophilic granulomatosis with polyangiitis as well in your differentials. Coming to the aorta again, in your aorta, if you're seeing wall thickening and enhancement, it means that you're dealing with an active stage of your large vessel vasculitis or your Cogan syndrome or IgG4 disease. If you're seeing aneurysms, you think of Behçet's disease or the subacute phase of your Takayasu and giant cell arteritis. If you're seeing stenosis, it means that you're dealing with a chronic phase of a aortitis. And finally, if you're dealing with abnormalities of your visceral tree, you need to consider polyarteritis nodosa as one of your prime DDs with other non-vasculitic lesions like your FMD and segmental arterial mediolysis as your differentials. So that's